All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to the open forum today. My favorite day today. We will be talking about our questions and we'll be discussing and exploring things together. So I'm going to start with Twitter and then I'll continue to switch between the live chat here and the Twitter. We have a lots of questions. I counted, I think we were about 46 questions on Twitter. So I'm going to try to do as best as I can to manage both the channels. So having said that, let's start. So today we will talk heart to heart as well. So Carolyn, good evening, welcome. So here is the set of questions on Twitter. The very first question, is Dexo or dexamethasone a temporary solution? And could the POTUS, President of the United States, be feeling temporarily better due to the drugs? The timeline of all of these cocktails together seem a bit early. Is it advisable to stay in the hospital after dexamethasone and ventilator? So that is a very good question. Fortunately, we have seen that President is actually doing better. He's back in the White House and he is doing good. So I'm going to show some of the folks who are here as well. So Raza, welcome. Mahesh, good morning. Jim, welcome. From Iowa. Vasika, hello. Vasant, good morning. James, good morning. Good morning. Shri, Siddhartha, welcome from New York. Siddhartha, you are a cardiologist, correct? Margaret McInnes, welcome. Margaret, once again, thank you so much for your contributions. Thank you so much for your support. We truly, truly are grateful. VP, hi there. McDonald's farmer, hello and thank you. You're most welcome. Kelly, welcome. Anthony, welcome. France, MD Ibrahim, Raza, Ecleon Productions, and France, and Rakesh, and the legends of Batch B, and so on. So Siddhartha says, no, a programmer. I work in computational neuroscience and in a graduate program for it. Siddhartha, it is funny. Today, I got this book delivered, Succeeding with AI. So the author, Velko, is actually my friend. So we had a discussion last week and he said, I have just finished my book and I'm sending it. So I'm going to read it. I love AI and AI-based neural networks and the programming for that. So we should sometimes talk. Okay. So Bambi here. I used to work as a heart-lung transplant team doing echo. Welcome. All right. So let's start with our questions. The very first question here, Gilead paid Adam Furstein, that is the name of the person or their name here. So is dexamethasone a temporary solution? So let's start answering this question. It is actually very interesting. So here is how it is. We know that we have the innate arm and we have the adaptive arm, correct? And then adaptive arm we know is further divided into humoral and cytotoxic. And for our discussion, this would come up many times, so please keep this in mind. Now, dexamethasone or steroids generally would suppress all of this, plus inflammatory system as well. Now, is that a temporary solution? Yes. When dexamethasone is given, it would suppress the immune system for some time. It's a long-acting steroid compared to methylprednisolone or prednisolons. So yes, it would have a mechanism of action for some more time, but still it is a short-term immune modulation. Now, your question here, that is it going to temporarily affect the President of the United States or basically anyone who gets this? So let me say this right off the bat. I really wish, and Trump said this, he said, I would provide the same drugs to everyone for free. I hope he does that. Check this out. As soon as he became sick, they took him to the hospital. They gave him aggressively the treatment, antiviral plus immune modulation, and he is doing much, much better. This is how we should treat everyone in the US. And believe me, there will be very, very few deaths. we should do this. So again, is this temporary? Yes. Why give so many drugs all at once? So it's very simple, actually. So let's say here is a cell, and the virus is getting into the cell and infecting it, and then it is going to come out of the cell and then go and infect the other cells. So that is the virus itself. And for that, we need to give antivirals. So the antiviral they gave, at least the one that publicly we know, is the remdesivir. Now, is remdesivir a great SARS-CoV-2 antiviral? I think so far we do not know, but it does say that it cuts the hospitalization time significantly. So there is something that did there. And of course, we know there are toxicities and everything. So maybe a different antiviral, but an antiviral is given right in the beginning to start to bring the virus count down. So when the virus counts are going down, then at the same time giving dexamethasone is allowing the immune system to be modulated downwards. Now, there are two possibilities. If the timing is wrong and we are in the early part of the virus replication and you give the immunosuppression, then what would happen is that the immune system is suppressed and the virus is actually going to start replicating. Luckily, we have given antiviral as well, so that is going to trap the virus and not let it replicate, and the immunomodulator is going to check the immune system, and so the person is going to stay as stable as possible. On the other hand, if the person has reached a phase where there is immune dysregulation, then the dexamethasone is only useful and the antiviral is not. So I really think that this is the right combination to do, and we are seeing the result for that as well. And of course, Regeneron's antibodies that were given acted as an antiviral as well. So I'm going to leave that one piece out from this discussion because there are more questions about Regeneron's antibody later on. So I don't want to repeat there, but I don't want to repeat here and then repeat there as well. So we'll talk about it later. But just for the time being, just know that the Regeneron's antibody acted as an antiviral as well. So good question. Now, the timeline of all of these cocktails together seems a bit early. Is it advisable to stay in hospital after dexamethasone and ventilator? So look, the ventilator is a huge deal. So once somebody is on a ventilator, they're going to stay in hospital for some time to be rehabilitated. On the other hand, if somebody has been on dexamethasone, look, I think for President Trump, the services that were offered, the medical services inside the White House were sufficient and plenty as well, and probably like an ICU. So he had the facilities available. If it is somebody like me or you who may not have that kind of facilities following us around, then yes, we'll have to be in the hospital while we are given dexamethasone. But I'll keep saying this, please look at how they treated him early on. I still feel that there are some things that they could have done even more. For example, ivermectin could have been given, hydroxy could have been given. There are some other things that could have been given. But whatever they did, within 2 days, they got him out of the, progressive disease. This we should, excuse me, this we should do for everyone who is becoming sick. All right, so that is that question. The Cedar Maga, so I see that this person account posts a lot of I think links for they have hydroxy and other things. So here this is really just a various prophylactic drugs and their quantities. So thank you very much for that. Sandeep Mishra says, respected sir, what is your opinion regarding abroxyl or N-acetylcysteine for COVID prophylaxis or management? So first of all, Sandeep, they both function clinically similarly. They both are mucolytics. But NSE has a different mechanism of action, and the Ambroxol has a different mechanism of action. So let me just very quickly explain what are their basic differences. NSE, as we have done, and I have put the videos link in the description so you can check that out. NSE is a mucolytic by breaking the disulfide bonds, correct? Plus, it helps with the antioxidation. So these are the two things that are really important. And we know that the disulfide bond breaking is also interesting when the viral fusion is occurring. And the antioxidation is also important for better systems defense. On the other hand, Ambroxol ambroxol as much as it is also a mucolytic. So clinically, they both function the same. The patient would feel the same effect, that the mucus is becoming lysed or dissolved and liquefied, and then they can throw it out. But ambroxol's mechanism of action is different. What ambroxol does is, number one, it goes into the cells, and over there, it changes the pH of the cell organelle. And number two, it causes the cell, especially type 2 pneumocytes. Type 2 pneumocytes, we have done the discussion in the past. They are part of our respiratory system, and these cells give rise to type 1 pneumocyte and the type 2 pneumocyte. Plus, they are helpful for making surfactant, which is the lubricating or the wetting surface of the respiratory system. Surfactant actually reduces the surface tension of the water present in the alveoli and allows them to stay open. So the ambroxol actually allows the increased production of surfactant, which then causes mucolysis, and that is the function of it. This function can also be used somewhat for defense from viruses and bacteria as well. And what does that mean? So imagine that this is an alveolus and here is the airway. What happens is we are continually producing fluids or surfactant, and then we are moving them with cilia. So remember, cilia are not in this part, but slightly above in the respiratory system. We have cilia that would continuously beat those fluids or surfactants that we are producing upwards till the time that that fluid comes here, and either we swallow it or we spit it out. So that is a defense mechanism. Bacteria and viruses get trapped in that wet fluid, and then they are moved up and either eaten up or thrown out. So now to answer your question once again, Sandeep, the function of NSC is different from the mechanism of action of ambroxol. However, they both can provide defense. NSC can provide defense by oxidation or by being an antioxidant and by breaking disulfide bonds. And the ambroxol can offer defense by producing more surfactant and creating the healthy respiratory airways, plus having the mucociliary elevator function more and bring the virus and bacteria out. So I hope that works. I'm going to answer a couple of more questions here on Twitter, and then I'm going to come to the live here. Please, on the live side, if you have a question, please write question with your statement so I can find it and talk about it. So here, next. J. Kirby, will mRNA vaccine be able to cross the blood-brain barrier? Very, very interesting question. And some of this some of the answers venture into the anti-vaxxers type community science as well. So I'm going to answer this as much as I think is the correct way to look at it. So here is what happens. We know that brain, so let's say this is brain, and here is the spinal cord. And we know that brain and spinal cord, I'm just going to make a simple illustration around this. They're covered in coverings that prevent the blood system to enter the brain. So they are protected, they are covered. And then there is blood-brain barrier, where we have talked about it in the past, that from the blood vessels, the substances cannot flow out like they do in the other parts of our body. There are tight junctions here, and it is very tightly controlled that what gets into the brain and what gets out to the brain tissue. And so these tight junctions are really tight, and there are channels present here that allows selectively what things are going to come out or what things are going to go back. So this is a simplified way of saying this is the blood-brain barrier. Now, can a vaccine cross the blood-brain barrier? The answer is it will depend upon the state of the blood-brain barrier. It is possible that the blood-brain barrier is inflamed for some viral or bacterial infection, and then it is little more open. So for example, here is the blood vessel, and the cells are inflamed and they have more spaces produced between them or amongst them. and from there, the fluids and things can come out. So that is one possibility. A second possibility is that possibly vaccines might trigger immune system, or might trigger damage to these cells here, which would then cause the cell to become inflamed and swollen, and then the gaps would appear between them, and through them vaccines and other substances can go into the brain. So normally this should not happen. So that is one. Secondly, the messenger RNA based vaccines are usually inside the lipid droplets, correct? So that is the basic technology there. That is the basic science there, that we have small, tiny spherical droplets that are made up of lipids. And then in these droplets are the, so let's say if this is the vaccine, this is the messenger RNA, it is contained within this sphere, and then the sphere is lipid. It can actually enter into the cells and go to the inside of a cell. If that is possible, then these blood-brain barrier systems may allow a cell, the cell in there may allow a lipid particle to pass through it. However, that is a point of testing a vaccine and trialing a vaccine to see would it actually do that. The particle size is big enough, and it is engineered in a way that it cannot just start crossing the cell either through the junctions, crossing either through the junctions between the cells or through the cell itself. So the short answer now is that the vaccine should not enter the blood-brain barrier. That is how it is manufactured. But if the blood-brain barrier is impacted for some other reason, then there may be gaps through which vaccine may be able to enter the blood-brain, enter the brain tissue. So good question. Here, C natural nurse. Dr. Bean, I want to know if the antibodies given to a patient with Regeneron therapy leads to the development of T-cell immunity, or are these antibodies temporary and do not lead to the development of T-cell immunity? I hope this question makes sense. So yes, it does make sense, and I'm going to answer it. And the second part is, I see natural nurse says, could giving a patient antibody therapy possibly inhibit a patient from developing their own antibodies or developing less antibodies than would have? Could this prevent a patient from developing T-cell immunity or less their T-cell? So let me explain what Regeneron is. And if you wanted to see more of the mechanism of action, I have done a detailed discussion about just the Regeneron. So please see that separately. Here, let me just very quickly explain that what these antibodies are doing. So the question here is, if these antibodies are given, then would there be immunity, T-cell immunity that would develop? So the short answer is no. And the reason, what is Regeneron's cocktail? Regeneron, I hope I write their spellings correctly. Look, this is passive immunity. This is passive immunity. This you can say, and I'm going to use loose term here, you can say this is an antiviral behavior, or a substance that is going to behave like an antiviral. What does this mean? What we are sending in the body are antibodies. Antibodies that can go and bind with the the coronavirus spike protein. And the Regeneron's antibodies can bind to more than one parts of the spike protein. So this is why they call it cocktail. Now, these antibodies are not going to be antigens. Normally, external antibodies can be antigens as well, but they're not going to be antigens like a coronavirus. So they are not going to initiate the immune system to produce antibodies against the SARS-CoV-2. These things themselves are the antibodies. So there are two ways to introduce antibodies in the body. One is you send in the virus or the particles of the virus. So these are vaccines. These vaccines would go in and cause the immune system to become triggered, and the B cells would produce antibodies. This is called active immunity because we have trained our immune system to produce antibodies against this antigen. On the other hand, but keep in mind that this would take up to from 7 to 14 days. On the other hand, if we don't have that kind of a time, for example, with President Trump, and we want the virus to be tackled right away, right in the beginning, then what you do is you produce those antibodies outside, which Regeneron has done, and then you send them in the body. So they actually go in and act as antibodies and start functioning against the virus and start mopping it up and start clearing it out. This is called passive immunity. Now, passive immunity would only last for 3 to 6 weeks. Some antibodies are engineered in a way that they might actually stay alive in the body or not decay in the body for about 8 weeks. So this is a protection given from 3 to 6 to 8 weeks. Hopefully during that time, our own immune system has also started responding to the virus and started producing our own antibodies, and those would then take over from then on. So what is the benefit of Regeneron's antibody then? The benefit is that if the virus is replicating in me and my own B cells are not ready yet to produce my own antibodies, and I need antibodies to quickly check the virus and keep it low in quantity, then you give antibodies from outside. That is what they had done. So this is called passive immunity. I would call it an antiviral behavior they did by sending in antibodies from outside. And I know that medical professionals are going to say you cannot say this is the antiviral behavior. I know that. This in more simpler terms is what is going on. So I hope that this answers this question. Will these Regeneron's antibodies help produce T-cell responses to coronavirus? No. Would they help produce or trigger our own B cells to produce more antibodies? No. They themselves are antibodies that would just go in and work while our own system is getting ready to produce antibodies. All right, so I'm going to look at the live for a few seconds here before I go back to that. All right, so I'm going to see if there is any question here on the live side. I don't see any question word here. Okay, so I feel that there is no question on the live. There is one, William Days. So question, I go to early senior morning, 6 a.m. at Walmart on Tuesday. On other days, I am in self-imposed isolation. Can I just take bromhexine on Tuesday and not on other days? Yes. The important thing is that bromhexine and I have a study today that I'll show you which says bromhexine is not that effective. The point I think you're making is that can we take something that would help prevent the viral entry, and can we just take that on that day? So yes, maybe a day before as well will be interesting as well. Maybe a nasal spray will be interesting as well. But yes, this can be done that it is taken that day. The question that we would have to answer is that if, let's say, you became exposed, let's say you're not wearing a mask, and you became exposed to a higher dose, which bromhexine's dose was not able to tackle, then if you don't take more bromhexine, then the virus may start replicating. So can you take it that day? Yes. I would say that 6 feet distance and the washing your hands and wearing a mask, that kind of things are important as well. Good question. So there is a Fauzi Sultan says question, have you seen any side effects from using quercetin 900 milligram, zinc 50 milligram, vitamin D 10,000 IU as a prophylaxis? Seems to trigger RA joint pain. So Fauzi, I use 10,000 IUs almost daily for vitamin D. I do take calcium, magnesium, and K2 with it. Fortunately, I'm fine. Zinc 50 milligram, I have not seen anything in me or the patients that have been taking it. Neither have I seen anything with quercetin. So then the question is, what may be triggering it? My recommendation is to stop one of these things at one time and see what happens, and then identify what is causing it. Maybe there is some of these substances, maybe their quality is low, or maybe your body is reacting to them. So there is a question, Carolyn says, would you have started with ACQ? And there is a question here as well on the Twitter side that says, if you got me, Mubin, if I got COVID-19, would I take ivermectin and hydroxychloroquine? And if yes, would I take it separately or in combination? So I would give you my management or my practice with my patients is that I used to give hydroxychloroquine with quercetin and zinc and those things. Then as I saw ivermectin was very effective and very safe as well, I started switching to ivermectin. And then in some patients, I gave both. So if I have it, I would take both. And that is how I would do. So Luke Caspi says, question, would ivermectin and similar take the place of the antibodies? If you come to me and you say, you have just gotten COVID-19, we have ivermectin, plus we have antibodies, which one would you like? I would say, give me both. If you said you can only take one, then I'll say the first day, give me the antibodies, and the next day I'll start on ivermectin. But if I was the one who was treating a patient, and I had these two things available, I'll give them both. The reason is I would like to be more safe. Ivermectin does antiviral activity, awesome. Antibodies are doing the same thing, great. Let's do them both together. Okay, so I'm going to go to the end of today. So Logic has a question. If taking NSC, quercetin, EGCG, zinc, vitamin D all did work, and let's say the viral load was so low it prevented symptoms, would you still produce antibodies? Antibodies will be produced. The question, I think it is interesting to say, let's say you're taking all of these things, and within 2-3 days, your innate arm is able to take care of the virus. Will we have enough viral load available for triggering the adaptive arm? So I think the adaptive arm would still be modulated. Maybe the antibody titers will be less. However, because the memory B cells will be formed in this whole process, and memory T cells will be formed in this whole process, and innate arm will become trained, that means that when the virus will attack again, our our own immune system will respond. So a good question. It is possible that in the beginning the immune response is low, but because we have memory, when the response will be exposed again, then we'll have robust response. Carolyn says, do you think Trump should be taking a prophylactic since passive immunity is short-lived? So here's the deal. He was given passive immunity to allow his own body to start producing antibodies. With that, of course, he's given dexamethasone as well to kind of modulate his immune system downward so it does not become runaway. Does that mean that by now he should start producing his antibodies? If he has about at the border of 6-7 days, then ideally his system should have started producing his own antibodies, and he does not need further help. So for that, what they should do is they should do an antibody titer test on him to see what is the antibody level. If his antibody level is still not enough, then they may need to continue to support him with either the Regeneron's antibodies or with remdesivir like antiviral, or with some other mechanism. Remember, they are suppressing his immune system. So it is possible that immune system does not kick in that fast and that intensely. So that they should just do a test, and based on that, they can decide that do we need to support him, or he's fine and has his own antibodies now. Good question. I am so excited that Cool Beans have such great questions. You know that I have seen other channels as well. Our channel and the tribe here is the most informed to the depth. Don Thrasher, and after this question, I'm going to go back to Twitter and handle some of the questions over there. So Don Thrasher says, Dr. Zaman study showed 80% of COVID-19 patients had eosinopenia. Now a patient that high eosinophil count took ivermectin suspecting COVID, tested now with no absolute eosinophils. Thoughts? Don, can I actually go through the data? Can you show me some study or link? And I would go through this and I would answer it maybe next week, or we can discuss it on Twitter. But I would like to look at the data first, so that I can make up my mind that what is happening. One more question here. Jenny Simmons. Question: how does the body clear a virus that crosses the blood-brain barrier? So brain has its own immune system cells as well. And these are the brain's microglia or glial cells. So brain has its cells that would act as immune cells, that would act as macrophages, and they would work and clear the virus. So brain has its own system. All right, so back here, question, some say test positive again. So this is an interesting one. So there is someone here, Claire Noxie, who's saying that morning all, I posted a couple of days ago about weird new breathing issue. Had a test yesterday, positive again. Anyone who's had it second time, please tell me it's not as bad as the first time around. I'm absolutely terrified. I still have so many issues from the first time. So I have seen reinfection I've never seen reinfection. And here we are seeing a reinfection. There has been a couple of other cases as well reported for the reinfection. The question is, did she really recover, or he really, I think she is a she, did she really recover the first time around? Was the virus still present in her, but the symptoms the immune system really took care of the symptoms, and she felt that she's better, and is the virus still there? So meaning, is she in a carrier state? I do not know. So the question is, some say tested positive again. My doctor says no. What does this mean for vaccine? So simple answer. From a vaccine's point of view, vaccine has to create antibodies, or has to create enough response that the antibodies will be generated and T-cell may be activated as well. The cases of, let's say this case is a case of a reinfection, then this would be one more case out of 37 million. We have 37 million cases so far, and I think there are 2 or 3 confirmed. If let's assume this is a confirmed case of reinfection. If that is the case, and we have the 3rd confirmed case. So 3 out of 37 million, and she's saying it is not as bad as before. I would not worry too much about it. It does not hurt the chances of a vaccine to help the community. Hoffer says, question, how many people died of coronavirus? How many people die of the flu? How many people died with coronavirus? How many people died with the flu? So Hoffer, thank you for this question. And I see this comment a lot. And some people have been sending me this as well. And they keep saying, what do you think, how many people have died from COVID versus how many people have died of COVID or with COVID? What they're saying is the following. They are saying that if a person gets COVID-19 or the SARS-CoV-2, and the SARS-CoV-2 is the sole reason for killing them, then they would be the legitimate count for a death from SARS-CoV-2. On the other hand, if they have a comorbidity, for example, they have a cardiovascular failure, or they are diabetic, or they are immunosuppressed, and they got the COVID-19 virus, SARS-CoV-2 virus as well, which accelerated their other system, which stressed their other system and caused the death. In that case, this death should not be counted as SARS-CoV-2 death. And I'm also seeing that some of this is then used to say that the 200,000 or 212,000 deaths in the US are not really 212,000 deaths in the US. They are lesser. So as much as I think that this is a really bad way to look at things, I would just simply give you one suggestion. Worldwide, we are counting deaths in the same way. Everywhere, elderly who are affected by this virus, with or from, most of them are with this virus. they are dying of the comorbidities as well. Their hearts are getting under pressure, or their lungs are failing, or they're developing ARDS because they had comorbidities. And they're counted as SARS-CoV-2 deaths or COVID-19 death because that is what triggered and accelerated it. So if we really want to, and I know that some of these folks are using this to say, America really doesn't have those many deaths. The number of deaths are probably 6,000. If we use the same formula, then applied in the rest of the geography and the rest of the globe as well, then many other would go down in a similar proportion. We would still come back up with the same bad outcome. So I do not want to indulge into this kind of a discussion that is it from or is it with? It is a good question. It is an interesting thing to research and look at the science of it and then apply it globally. But at this time, we know that we should do better in the US. So I would rather look at all of those deaths and say, how do we improve now onwards? For example, vaccine is very important. For example, the regime that is given to President Trump, that should be available to everyone. Why not? And then let's fix it. Let's not have more people die. So I would go in that way instead of trying to say there are no deaths and then say, okay, everything is fine. Luke Henry, what do you think about Trump downplaying the coronavirus? Downplaying the corona. So there have been lots of news channels that have been reporting that Trump has said that I downplayed it. That is more of a political thing from his end. I just know this, that we are not doing good. We are not doing good collectively. I don't think that it is the blame all sits with Trump or blame all sits with CDC or FDA or one doctor or 10 doctors. We collectively in the US have not done well. Now, Trump downplayed it. Maybe if he was more careful, maybe there was a sense of urgency in the people below him who were working for him. Maybe that's a speculation. Maybe downplaying, as he says, I wanted to keep the nation out of panic and anxiety. Maybe that also was useful. I would have seen an entirely different way of managing in the US. And in that, I don't think Trump was responsible. Again, I'm not saying Trump did all well. I'm just saying that we should look at the healthcare leaders to see what they did compared to a political person to say, what was his politics and how did that happen? Agreed, there are blame to be put everywhere. And then as a president, as the CEO of the country, eventually everything lies with the buck stops with him, fine. But I think the healthcare system did more damage. And I would, if I was in his position, I would keep alerting and alarming the nation to say, be careful, be safe, be careful, be safe, don't do this, be careful. So that is how I am. And you have seen me doing this here as well. With the school opening, I keep saying, don't do it. So I am on that side of not downplaying. Sam Sub says, what are your thoughts on the virus's ability to hide out inside of cells by disrupting MHC antigen presentation? So we have that over here. It is a beautiful study and the link is in the description as well. I'm just going to explain. Here is the basic question and the mechanism for that question. I loved it. Mechanism is this. So I need your attention for a few seconds. This is actually an important question and interesting viral behavior. And this is a hypothesis. This is not something that has been confirmed yet. They have confirmed in their lab that what they're saying seems true, but it has not been confirmed at a bigger level. Here is what they're saying. This is a cell. We have two kinds of cells, nucleated cells and anucleated cells. Those cells that have nucleus in them and those cells that do not have nucleus in them. This, for example, red blood cells do not have a nucleus in them. For example, platelets do not have a nucleus in them. On the other hand, we have cells that have nucleus in them. The cells that are nucleated are further categorized into two types. One category of the cells are those that are immune antigen presenting cells. We call them professional antigen presenting cells. You can think of them as policemen, cops. Their job is to arrest and catch the pathogens or the bad elements. On the other hand, you must have heard about citizens arrest as well, that are normal cells can actually, when they become infected, they can also present the antigen, the piece of the pathogen on their surface on MHC-I complex, major histocompatibility complex number 1. When antigen is presented on the surface by a professional antigen presenting cell, we say that they present it on MHC-II. So when we talk about a macrophage, that uses MHC-I and MHC-II because its job is to present it on an MHC-II. When we talk about dendritic cell, it presents it on MHC-I and MHC-II. When we talk about a B cell, sorry about my throat. When we talk about a B cell, it does have antibody IgD that it uses to present, plus it can use MHC-I. The point is, every cell that is nucleated, when they get infected, they can present the antigen on their surface with MHC-I. Good? This MHC-I molecule, when it presents part of the pathogen virus, then it causes the cytotoxic T cells to become activated and kill this cell itself. And we have done this mechanism many times. Please recall the T helper 1 pathway, where eventually we reach the cytotoxic T cell. If that cytotoxic T cell is connected at that time with another cell that is infected and is presenting on MHC-I, then this mad cytotoxic T cell is going to kill this cell by perforins and granzymes, right? So we know that. What they're saying is in this study that if a cell is present, if SARS-CoV-2 is present in a cell, what it does is that it down-regulates the production of MHC-I. It suppresses the cell from producing MHC-I. That means the cell cannot tell on it. The cell cannot tell other cells that, hey, I am sick, because the presentation that it has to do, it has to yell out and say, I am sick. That it cannot do because the virus has suppressed its MHC-I production. That is very, very interesting. If that happens, then the virus is going to stay hidden in here. It's going to replicate in here and then eventually come out of this cell. But immune system, when activated, will not be able to attack this cell because for that attack, MHC-I is needed. And that is the study that they have done. That study is here. This is that study, and I have their study in the PDF form here as well. The summary of that study is what I've just told you. What happens is that when this virus, and they say that SARS-CoV, the previous SARS-CoV, did not have this capability. SARS-CoV-2, now this coronavirus, has this capability of producing proteins that would downregulate the MHC-I. And it does that by open reading frame 8. That genetic part in the virus produces the genes or proteins that in turn helps the virus suppress the MHC-I production. Beautiful mechanism, of course, lethal for us, but virus has a lot doing. So the question here, excuse me, what are your thoughts on the virus's ability? So yes, it is very, very much possible. I think we just need to replicate this process a little more and confirm it. Hello, Sunny says, can you please talk about the situation in India? So Sunny, I actually looked at the India's map here. So if you see India, almost 7 million cases, more than 100,000 deaths, and then they are very slowly ramping downwards, and the deaths are actually still stable and happening. What I will do is, I do not know the factors in India, and I'll have to do a deeper dive before I can talk more confidently for what is happening there. So if you don't mind, I'm not going to answer your question here in Twitter because I haven't prepared it enough. Plus, we don't have the time to discuss this here for long. I would do a separate discussion. Maybe tomorrow we talk about India. I'm curious about this whole issue as well. So here, I'm so sorry. Nick Holling says, is it expected that people treated with Regeneron's CoV-2, so that is the Regeneron's antibody, that have COVID would have lasting immunity? My thoughts were that despite the monoclonal antibody only lasting 4 to 6 weeks, the body would also have created some normal immune response to the virus during that time. So that is exactly the answer. The passive immunity provides cover for the duration of the time in which the active immunity or adaptive arm becomes active. So the Regeneron's antibody themselves are not going to give a longer lasting protection. They're going to be there for 4 to 6 weeks, depending upon how they manufactured them or engineered them. Meanwhile, our own immune system has to get up and get ready and produce its own antibodies. So good question. Bert Lennon, and after this question, I'm going to come back to the live. Bert Lennon says, Dr. Bean, I've watched every one of your videos for at least 3 months. Very impressive, very professional. If you were to contract COVID-19, so I answered this question a little bit earlier. So if I had to contract COVID, if I contracted COVID-19, would I take ivermectin and hydroxychloroquine or both besides the rest of the cocktail? I would take both. If I had safety concerns, I'll take ivermectin. If I was given just one choice, I will take ivermectin. Then if I have hydroxychloroquine only, then of course I'll take that. But if I have them both, I'll use them both. All right, coming here to the live site. How are you guys doing? So we are 6:48. So Max says, I saw a question here. So Blue Pill says, question, no way lol. Or are you just speaking with someone whose name is Q? Okay. So there is a wellness path for me, says Dr. Barry Sears believe that long haulers don't have the ability to turn on the resolution path for their inflammatory resolution process. And very simply, trying to agree here. When I speak with other doctors and we talk about long haulers, I have a very simple message for them, and that is forgetting about the mechanism. We know that there is something going on because they have symptoms. So that means their immune system is still dysregulated. Their immune system is still responding incorrectly. Now, that response, is it because the virus is still present and kind of triggering the immune system? Or is it because the virus is actually gone, but the immune system is still forgotten the path of becoming reset? Normally what happens is when the immune system becomes active, simultaneously there are T helper 17 type cells or T regulatory cells that become active. They are activated as well simultaneously. And a few days later, they start suppressing the system to say, now you calm down, immune system, and don't overreact, stop now. And of course, in these patients, that does not happen. So either the virus is sitting in there and continuing to poke the immune system and asking it to continue to work, or the immune system has forgotten its way to go back to the normal state and it has become dysregulated. There may be other mechanisms, but so this seems very plausible. And I have been talking about it for some time as well, that either the patient is in carrier state, or Dr. Paul Marik said it is the dead virus, the broken pieces that are still sitting in the cells, to which the immune system is reacting until the virus is cleared out or the debris of the virus is cleared out. Immune system would continue to do that. I actually agree with him, but I do have an opinion that the viral debris should be cleared out within a week or 2 weeks. It cannot continue for 2.5 months or 3 months. And I'm seeing patients who months after were still having the symptoms. So in that case, it may be in the early phases there was virus itself, then the viral debris, then maybe the virus itself persisting for longer time, or maybe dysregulated immune system. So good question or comment. There's a comment here. Shivaji says, I contracted COVID a month back, recovering. My GI symptoms are disturbing, colicky pain and loose stools. Please discuss about this problem. GIT, SARS-CoV-2 affects the GIT as well. So of course, what this means is that the SARS-CoV-2 in the GIT system is still hanging out somewhere. Or as I just said, it is possible that the immune system, so we have MALT, right? Mucosa-associated lymphatic tissue in the GIT. Maybe the GIT system's MALT has become dysregulated. So ideally, what you should do is get your labs done to see what is your ferritin and D-dimer and CRP, and then if possible, look at the immune system's labs as well to then see where do you stand. Maybe do the fecal RT-PCR as well to see if you are still shedding the virus. Normally, you could be shedding a virus from your fecal route for about 2 months. So get those tests, do an RT-PCR with the nose, get an RT-PCR from the fecal route, plus get your other labs, and that would tell you what kind of a state you are in. How is everyone doing? I just start coming in and start shooting the questions and answers, and I just hope that you are okay. So there is a Bergeron, Dr. Bean Medical Lectures. Can you talk about the Great Barrington Declaration? Yes, I looked at it yesterday as well. I like what they're saying. So even essentially they're saying that, all right, let's go back and open up the society. And I read it. The question that I have for them was, and maybe I did not look thoroughly enough, so if somebody has seen that data, please tell me. The question I had was that you are basing your opinion or your recommendations on what facts? So ideally, there should be some references to say, here is a fact, here's a fact, here's a fact, here's a study, here's a study. Based on that, we have following recommendations. So I was actually planning to talk about their position and their petition a little bit separately. But yes, I went through it. I still wonder where is the data that they are basing on. So there is a good question. I just caught it. There is no word question, please. So Myron says, why does Paul Merrick says the viral phase is only 8 to 10 days? That is the usual. If our immune system responds with its might, with its normal behavior, then it can catch a virus and take care of it within 8 to 10 days. So again, RT-PCR is not a great way of really knowing that the virus is actually gone after 8 to 10 days or inactivated after 8 to 10 days, because RT-PCR is going to pick up the fragments of the virus and also say positive. But from general study of the immune system, this is the behavior of the immune system. Maybe in this case it is wrong. SARS-CoV-2 has broken so many rules that it's not even funny. It's scary. So I'm going to go back to the Twitter for a second. Pratik says hepatitis C virus discovery. So Pratik, we should talk about hepatitis separately. This is mostly a COVID-19 discussion. So I would like to, let me hide this thing. I would like to continue to talk about COVID-19 here. Ruchi says, Ruchi Banthia, hi doc, thanks a lot for being a great teacher. Please talk about the relevance of CRP in COVID patients. What is its significance in predicting the course of disease? So I have a couple of studies here. So Ruthi, this is one study where they have shown that the C-reactive protein, which is an acute phase protein, what does that mean? When the infection starts in our body, the innate arm actually triggers the liver to produce acute phase proteins that also help the innate arm to take care of the virus. C-reactive protein is one such protein. So if our immune system is becoming intense and responding more severely, then the amount of C-reactive protein would start going up as well. So it is a very important inflammatory marker. And here there is a study where they show that with every stage of the disease, for example, from mild to moderate to severe to very severe, C-reactive protein continues to increase proportionally. So there is a dose-dependent relationship of C-reactive protein to the intensity of the COVID-19. That means more C-reactive protein means more intense COVID-19. So Ruthie, there is one more study here, again, links in the description. Concentration of C-reactive protein remained high in patients who died of COVID-19 infection and could be a promising biomarker for assessing disease lethality. And we have talked about this in the past as well. Of course, Luffy thinks that this all is important, and because I'm talking, he needs to talk as well. So he is pitching in continuously. One more question here, and then I'll go back to the other side. So here is a Tony Karalikas saying that I've mentioned once, but the symptoms overlap between thiamine deficiency and long COVID. So what he's saying is that the thiamine deficiency symptoms and the long hauler symptoms are very similar. So is this a possibility that there is a depletion of thiamine, which in COVID-19, which then in turn causes the long haul symptoms? It is exactly possible. And he has given a couple of pictures here. So this is one, thiamine deficiency and the symptoms. This is another thiamine deficiency and the symptoms. I have zoomed in. So because of that, they don't show correctly. So yes, it is possible. Now, is it really that every time in the long hauler, it is really just a thiamine? That is an interesting idea. I'll have to research so long haulers, mostly fatigue, intermittent fever, sometimes cough, muscle aches, and sometimes breathlessness is what they see. So I'm going to go and look at the thiamine or beriberi as well. I feel not all of the symptoms overlap, but I'll have to kind of do some mapping to see if it is possible. And eventually we should actually look at the thiamine levels as well. It is a very fascinating thing to look at. Okay, so let's look at the live side. Question, have you seen the Germany study that used the supercomputer to image detail the spike protein? I have not, but I have seen a video of spike protein's function and how it is working. So I don't know, maybe that was supercomputer generated image, but I really was fascinated about it. And Morris, if you have the link to it, please send me the link. I would love to see it. Myron says, question, what does COVE do to mitochondrial activity, hint melatonin? So we have done that discussion in detail with the melatonin, that what happens is inside a cell, when there is inflammation or when there is an infection and the inflammatory cytokines are being produced, the dehydrogenase enzyme inside the mitochondria becomes blocked. And that next, it causes the blockade or stoppage of ATP production and melatonin production. Giving melatonin helps reverse that effect. So, of course, mitochondrial function is disrupted, and then melatonin production is disrupted. I think there is another question here. Although there is no word question, but 008 KLM says, the part of the spike protein that breaks off on entry to the host cell causes us not to feel pain from the damage caused? No. So if I go here, so let's say this is our cell. correct? And we know that we have the ACE2 enzyme here, with which the virus wants to bind. And we also have the TMPRSS2. It's a transmembranous protein, sort of. I call it a silly protein because it kind of allows the virus to enter our cell. I know that some religious folks became very upset with me that why do you call thing that God has made a silly thing? This everything made is great and important. I get it. I was being a little, I was just being more light. There was some levity. So anyways, so what happens is here we have COVID, and here is the spike protein, correct? So I'm making them big. So this COVID wants to enter the cell. So I'm answering this question that will the splitting of the separation or priming, as we call it, the priming of the spike protein, will that cause damage to us? No. So the TMPRSS2 would prime this protein and kind of divide it into two pieces like this. One piece becomes a springy structure that fuses with the cell membrane, and the other piece becomes a structure that fuses with the ACE2. So now imagine the spike protein becomes two hands. One hand on the door knob, and that is the ACE2, and the other hand on maybe the wall to catch them and then open up the door and then go in. So that is a basic process that happens. This split or priming does not cause us pain. Our pain is caused when the inflammatory system and the immune system responds, and we produce the local, remember, arachidonic acid pathways, leukotrienes and prostaglandins and prostacyclins and those things. Those things in turn cause pain by irritating the nerves that are present in the area, which then causes pain. Okay, so I'm going to take one more question here on the live, and then I'll go to Twitter. So Anthony says, Dr. Bean, Dr. Lance Sale and Chandler's must have done great work on thiamine, Elliott, Overtone as well from UK. Excellent. I would look them up. Thank you. Nebu says, question, patient who is on steroids post-transplant and with COVID positive, will the steroid be an issue at this early stage? So of course, this is a concern. They are supposed to be immunosuppressed, and they're deliberately immunosuppressed because they have a graft in their body, and we need the graft not to be rejected. And in the comorbidities, immunosuppression is one of the top comorbidities. I think we have the diabetes, I'm talking US now, diabetes, obesity, then heart failures, and then cancers, and then what is this we're talking about here? The immunosuppression. So immunosuppression could be because of things like HIV, and immunosuppression could be because we have deliberately caused the immunosuppression by either for the graft or for the cancer treatments and so on. So yes, this can be an issue, unfortunately. So Myron Bernie says, question, what Ayurvedic medicine is good for COVID? I am not an expert in there. The only Ayurvedic thing I discussed was curcumin. I will have to look up more, but I cannot say off the top of my head what may be good Ayurvedic medicines. I'm an allopathic medicine doctor, so I usually am more fluent with allopathic medicine. Curcumin is very good, yes. Okay, so, all right, I'm going to go to the Twitter for a few seconds and look at this. Don Weaver says, Nobel Prize winner Dr. Luis Ignaro talks about how nitric oxide is currently being used as an intervention in clinical trials to treat COVID-19. What are your thoughts on it? So I have Number one, a couple of articles here about the nitric oxide. So here, nitric oxide is a possible treatment for COVID-19, study finds. And then this is the other one where they're talking about nitric oxide and COVID-19. So let me just very quickly explain what nitric oxide does. So one of the functions of the nitric oxide, so we know that it is a vasodilator. So we use that vasodilatation, our body uses it for vasodilatation, that is fine. The action in case of viruses is that in the cells, when these cells are, remember I talk about the cells like neutrophils or macrophages or dendritic cells. These cells have phagocytes in them where they would actually capture the pathogen and then they would kill it by putting lysosomes on them or by putting enzymes that would kill them. Plus, they would produce reactive oxygen species. Reactive oxygen species which are lethal for the pathogens. They're lethal even for us as well. Reactive oxygen species, oxygen, can then interact with nitrogen as well and produce reactive nitrogenous species, which are as lethal as reactive oxygen species. So just like oxygen can act as an antiviral, the charged oxygen, similarly charged nitrogen or nitric oxide can also act as an antiviral. So the nitric oxide is antiviral and antibacterial. That is one. Second, this is an important one. Remember, we talk about our adaptive arm. So let me make macrophage here. Macrophage connects with a naive T cell. Naive T cell can go T helper 2 pathway that goes towards the immunoglobulins, right? Plasma cells, and we have immunoglobulins produced, or it can go to T helper 1 pathway that would go to the cytotoxic T lymphocytes, CTLs, and that pathway does a different way of working, that is cytotoxic. This is humoral. The nitric oxide modulates the immune system to go to this pathway. And now we have also seen in our past studies that this pathway of producing antibodies may not be the best pathway. It may be that the best is that the innate arm becomes strong and then cytotoxic arm takes over. And those patients where the T helper 2 pathway becomes more strong usually can become more severe as well. But nitric oxide's function is to take us into this pathway. So let me show you that. Nitric oxide also appears to affect a host's immune response with immunopathological consequences. For example, overproduction of NO in virus infection in mice is reported to suppress type 1 helper T cell dependent immune response, leading to type 2 helper T cell biased immunological response. So it may actually be antiviral, which is beneficial. It may actually end up causing incorrect modulation of the immune system as well. So I'm going to continue. As I understand it, this is the expected as bromhexin. So here is an important study to look at. This one is about bromhexin. So what they did was, in this study, they took bromhexin and they took some other drugs, for example, camostat and nafamostat and gabaxat. They are all serine proteases. They are all, you can say, TMPRSS2 blockers. And they tested their efficacy. And they found out that the least efficacious was bromhexin. And the best was nafamostat. So this is the study here, and that is what was tweeted to me, that it seems that bromhexin may not be as useful compared to the other ones. Excuse me. So yes, it is written here. The biochemical TMPRSS2 assay we disseminate here is a simple and HTS amenable approach to support TMPRSS2 inhibitor therapeutic development and investigation. So clinical trial of nafamostat for COVID-19 have been reported, and we believe it warrants evaluation given its superior activity over camostat as demonstrated herein. So what they're saying is that they're all TMPRSS2 blockers. The best one is nafamostat, lesser than that is camostat, and least is the bromhexin. Excuse me. So this is the same bromhexine discussion. What could be the mechanism behind long COVID causing blurry vision and changes to eyesight? So Raza, this is a great question. I looked it up for the pathological mechanism and I didn't find a decent one. And I am not yet ready to say that it is the optic nerve neuritis. So give me a few days for me to look at the reason for the blurry vision in long hauler. This is the first time I'm hearing it. So this was a good question. Unfortunately, I couldn't find a good answer for it. Jonathan Loon says, new clinical trial results have been posted for double-blind RCT IVM study. So this is the study here. And I love this one. What they are doing here is that they have taken ivermectin and doxycycline, and they have given them together to see what is the effect on the patients. And I would recommend that you look at the study. What they found was, so primary outcome, number of patients, I hope you can see this one clearly, number of patients with early clinical improvement. So in that primary outcome, if I open up the data here, in the ivermectin plus doxycycline, 60%, 60.7%, and in placebo, 44%. Similarly, if you see the other outcomes here, for example, primary outcome, number of participants with late clinical recovery. In ivermectin plus doxycycline, 23% recovered late, while in the placebo, 37% recovered late. Then secondary outcome, number of patients having clinical deterioration. And then for that, the ivermectin plus doxycycline, 8.7% had deterioration, while placebo had 17.8% deterioration. That was significant. So positive results. Study admits a second dose of ivermectin could improve outcomes. Doxycycline may have an important role. Please discuss. Yes, definitely. And we have talked about doxycycline separately. We have talked about ivermectin as well. My own way of giving ivermectin is that I give 6 milligram, depending upon the patient's body weight and their body habitus. So I look at all of that. But then I give them 6 milligram BD, that is twice a day. In prophylaxis, I skip every day or every 2 days. The half-life of the ivermectin is, I think, about 18 hours. So ideally, every other day it can be given, or every day it should be, I think it is 48 hours. Anyways, it can be given every other day. However, when a patient is actually infected, then I give it every day for 5 days. So I don't even bank on one dose and done. I actually just continue giving it. So I'm going to come back here for a second. So Marie says that report just came out today about how the eyes are affected. I'm going to read that as well. So I want to see what is the mechanism of action. Any question here? Okay. So it seems like there are no questions on the live side. I'm going to continue on the Twitter side. Question 1, how does the seasonal flu vaccine boost our immune system, or could you do a show on that? So we can do that separately. So far, I do not see that the seasonal flu vaccine would have effect on COVID-19. The only benefit can be that a seasonal flu vaccine would cause people not to have flu. And if they also have COVID-19 and now they're not coughing and they're not sneezing because of the extra one, for example, children and young adults, then the spread will not be that much. Otherwise, in the cold time, when, let's say I am a young adult, let's say I'm 20, 25, and I have COVID-19 and I am relatively asymptomatic, so I'm not spreading that much. And then I get common cold, let's say rhinovirus, and I start coughing and sneezing because of that, then I'll start spreading it. So, but I have not seen anywhere that there can be a cross reactivity. How has your opinion about what should be done for prophylaxis and treatment against COVID-19 changes lately? What are your recommendations for both if someone cannot get a prescription for hydroxychloroquine or ivermectin and cannot import these drugs legally due to regulation in the country? This seems like US. Anyways, the quercetin and zinc are very important. Vitamin D is very important. Keeping your levels greater than 40 nanogram per milliliter brings down the death rate in elderly with comorbidities down to 1.6%. From the study showed 7.8% in others whose vitamin D levels were low to 1.6%. So if you cannot get anything, then at least keep your vitamin D levels up. To keep them up, to make sure that they do not cause your kidney damage or they do not cause bone issues or GIT issues, make sure that you talk with your doctor, get your test results done, levels done, and then make sure that if you need to have magnesium and calcium and K2, you take them with it as well. So just do that at least. And then quercetin is in onions, the best form of quercetin. So red onions are very useful. Zinc is very important. So at least have that. What are your thoughts on Regeneron's antibody cocktail being used for prophylaxis, both from a medical standpoint and from an availability standpoint? Can a drug like this be prescribed for prophylaxis? So look, the Regeneron's cocktail is antibody, correct? And it is going to stay, let's say, in our body for 4 to 6 weeks. For that time frame, it is going to be really, really useful that if I become exposed, it's going to really help me keep the viral load low or zero. Now, can it be given to a lots of people at scale? That is a question really for Regeneron to answer, but it is a promising thing. It's a cocktail. It's 2 monoclonal antibodies. So I love this idea. And so for prophylaxis, I would say essential workers can have this prophylaxis. If I'm sitting here in the lockdown and I'm not going out and I am not an essential worker, I probably don't need the prophylaxis. I can just sit here and be careful. On the other hand, nurses and doctors and healthcare professionals and policemen and military men and people who are keeping the lights on while we are sitting at home, they need these kind of things. I thought that we should give them ivermectin and hydroxychloroquine. Just get out of the way and let them have these medicines. But if not, this is also very, very interesting. Antibodies, why some develop and some not developing in previous. So SIP's question is, antibodies, why some develop and some not in previous positive patients? How long for an antibody stay? Anything on COVID antibodies seems like forward talk on this lately. So I actually want to show Pia Dhagani's this little diagram here. So she has been seeing immunoglobulin G and immunoglobulin M in a patient after 8 months of recovery. So what they're seeing is that the antibodies stay longer, which is excellent. We knew that they stay for 3 months, then we knew that they stay for 4 months. Now we have someone who's sharing that the antibodies stay for 8 months. And Puya, I hope I'm pronouncing your name correctly. So if I see that and then I go down here, antibodies, why some developing and some not develop in positive patient. So look, we have seen that the immune system responds in various people in various ways. In children, innate arm is strong, so the antibody levels are lesser. In some other people, the cytotoxic arm becomes strong and the antibodies levels are less. And then in yet other people, antibody levels are more. That is one reason that our immune systems behave differently. Second reason is that in some people, immune system is just simply suppressed. It is not able to produce antibodies. So that, like immunosuppression by medicines or immunosuppression by viral infections or immunosuppressions by cancers. So because of that, antibodies could be less. Now, how long the antibodies stay? This is an important question. And from SARS-CoV-1, the antibodies stay for 3 years. And we just saw that 8 months is for SARS-CoV-2 as well. I still believe that antibodies would stay for 2 to 3 years. So I am not a antibody rapid decay guy that 2 months later or 3 months later antibodies are gone. So before I continue here, I'm going to go to live. So there's a question from Nipa Gandhi. Homeopathy medicine, Justicia adatora mother tincture, easily available in Amazon, is same as bromhexine. Will it work? Short answer, no. And the reason is that the concept of homeopathy, and I know now I'm going to get yelled at by many people, the concept of homeopathy, I do not agree with. That we dilute it enough that it becomes powerful enough. That is just wrong. So bromhexine itself should be useful. And we just saw today that nefamostat is better than chemostat, and that is better than bromhexine. So I like this comment by M. Ball. Age is nothing, vitamin D is everything. That is correct. Okay, I'm not seeing question. Can we use serum of duly recovered patients? So Sanjay says, so that Sanjay, yes, so that is a convalescent plasma. So we can use convalescent plasma, although we haven't seen lots of success with it, which I'm really surprised about. But monoclonal antibodies or monoclonal antibodies cocktail like Regeneron, they have tested them a lot, and they have seen if they work well with the coronavirus and the spike protein. So convalescent plasma is great, and I think that Regeneron's antibodies or other monoclonal antibodies may be very useful as well. And my disclaimer, I have nothing to do with Regeneron, no interest, no stocks, nothing. So don't think that I'm just pumping their stocks. Okay, back here to the Twitter. Hi, Dr. Bean. Do a few doses of steroids to treat early COVID infection cause immune suppression, or is it just long-term use of steroid that suppresses the immune system? Thanks for all of the teaching you do. It is really interesting. So RT, the immune suppression starts occurring when we give the steroids. And if we give steroids chronically, that simply means that we want the immune system to stay suppressed for long, and we cannot take the immune system, the steroids off, because it does not persist. So we have to continue to give. So the short answer is yes, when we give the dose, it starts suppressing the immune system, and then long-term immune system suppression by long-term use also occurs. The only thing is, in the long-term use, there are other things that happen. For example, there are effects on bones and effects on other tissues of the body which are detrimental. And so long-term steroid use is a problem. Plus, of course, infections and those things. Millie says, pH activity versus neutral diet to heal or stay healthy during COVID season. Good question. I think that acidic diet would actually be bad. Neutral or slightly basic diet would be useful, because the virus we have seen with the hydroxychloroquine, that hydroxychloroquine changes the pH towards alkaline, and that helps reduce the effect of the virus. But if we take too much of the basic system, then that itself is dangerous as well. So neutral to slightly basic compared to acidic. Question from K-pop Super Strong. If Trump took the experimental COVID antibody cocktail from Regeneron, even it's only a small study, why can't government do the same for hospitals to either use aviptadil, leronlimab, or bradykinin inhibitors for late-stage COVID patients as a hospital protocol rather than use for RCTs? So I agree with you. And I think that why can't the hospitals be given Regeneron's antibodies? And why not, I don't agree with remdesivir that much, but why not some antivirals, as you are saying here? Why not leronlimab? Why not dexamethasone? Why not treat patients early and get them out within a couple of days instead of waiting on them to become intense and then trying to struggle to get them out with ventilators? That just is wrong. Now we are educated enough about this thing for last 10, 11 months that we can do better. And you are seeing the result of doing better with President Trump. We should replicate that model for others too. Zukun FT Swisend. Does the daily intake of vitamin K2 have to be increased if the person is morbidly obese and is taking 3 times the amount of vitamin D he or she would take without the obesity? Is more vitamin K2 needed in that situation, or does it remain unchanged in spite of more vitamin D supplements? I think the vitamin K2 levels may have to be increased as well. But the important thing to note is it is the blood level of D, which is 40 nanogram, obesity or not. So to match that, K2 levels can be the same, obesity or not. The problem is the storage in the fat tissue. And I remember it with cat is on the ADEK, ADEK. K is also a fat soluble vitamin. That means K will get stored as well. So instead of me saying that the dose should be increased, what I would say is the specific level should be reached. And for that, if increase in dose is needed, then we should do that. Safety of hydroxychloroquine in pregnant and lactating women. It has been very safe. But please remember retinopathies, blood disorders, and the cardiac arrhythmias. So child is at risk if this happens. Women herself is fine, but people say they swear that they have in 20 years never seen any side effects. I have seen side effect with regular dose of hydroxychloroquine. In one family, there were 5 members, all developed arrhythmias. So just make sure that you are careful. Why is the incidence of the disease lower in females? There are so many theories about that. Some folks say that men are more exposed to kind of works that expose them to catch the virus. For example, going out and working. There are some societies where this is equal. There are some societies where it is not equal. Then there are some theories that it is the hormones that are different. Then there are theories that they say that women are cleaner compared to men. They wash themselves better. They take care of themselves better. So they have less chances of transmission or catching because they are clean in general compared to men. So there are many such theories. I haven't yet seen any mechanism, pathophysiological mechanism that says that here is a reason. Mirror 91 says, I think it's important to remind not to take ivermectin and benzodiazepine together. People will use a lot of anxiolytic in case they are positive. Other problem with ivermectin is that you don't know if in each they will give you steroids. So what to do? It in hospital, I think. It seems to me ivermectin can be very dangerous. Ivermectin can be dangerous if it crosses the blood-brain barrier. So please, Dr. Bean, can you discuss steroid tapering mechanism? So I'll discuss my mechanism. So this is not going to be true for everyone. Every patient would have to be tapered differently based on how their situation is. My mechanism of outpatient, long hauler situation. So I'm not doing steroid tapering mechanism. I'm just talking about long haulers. Steroid tapering mechanism, there is a huge set of literature for what is the right way to taper steroids. So I cannot cover that here in just one question, but I'll tell you what I do for long haulers. So what I do is this. So let's say day 1 and day 2. Breakfast, lunch, dinner, breakfast, lunch, dinner. So thrice daily, 5 milligram prednisolone. Or delta cortril or prednisolone. Then the next 2 days, day 3 and day 4, breakfast and lunch. breakfast and lunch. And then next 2 days, day 5 and day 6, breakfast only. This is how I taper. One general comment on tapering is that when you are tapering the steroids, you keep them early in the morning, as early as possible. You do not give them in the evening times. So that is how I taper for long haulers. Again, this is not a discussion of tapering. Tapering itself is a long, big discussion. Okay, so then I'm going to go here and maybe a couple of more questions and then we stop. There are a lot more questions here as well that I am unable to answer them all. So I'm going to try to do some rapid answers. Dr. Say, refresh your Twitter feed. There are new questions on the thread. So I already have so many questions on the thread that I don't think I can work on them. Logic says, 1 to 10, how confident do you feel that vitamin D, NSE, quercetin, zinc will prevent COVID? I will never become confident that we can have prevention of COVID. The reason for that is that everybody has a different body habitus and the immune system. So just saying, let's say if I start taking 5,000 international units of vitamin D, I have no idea what my level is. So it is the 40 nanogram per milliliter and above. Similarly, what is the right dose of NOC and what is the right dose of quercetin? That is still to be known. So I think there are good prophylaxis. There are good studies that 50 milligram of zinc and then 500 milligram of quercetin, NSE just take on label dose. Vitamin D, bring your level to 40 nanogram per milliliter and above, whatever units you need for that. And I think that mortality rate just with the vitamin D goes down to 1.6% from 8%. So that I would say, I can't say for prevention, but for safety, I am very, very confident with that. So let me just do some rapid fire answers here and see if I can take care of these. What is your real personal opinion on what the ivermectin studies are not being peer reviewed? I think that doctors have a bias. I talk with many friends and doctors, they just simply say, we don't want to use ivermectin, we don't want to use hydroxychloroquine. So these kind of doctors like us who say these things work have now become sort of a separate group in the medical society, and the mainstream medical society or medical folks don't think these are functional things. And I think the reason for that is twofold. One, they don't study it. And secondly, when they don't study it, they don't use it. So neither they become aware of the mechanism nor they become aware of the effect. I just wanted to know if genome sequencing has the resolution and precision to show who infected them. So this is a good question. Lisa Boll says, in the Trump's White House, do we know exactly who was a super spreader over there? Who infected others? And so, yes, there is a way to actually follow it. I think it would be very expensive and tedious to do that. But what happens is that when coronavirus is present in one person, so let's say this is person 1, and they have coronavirus. This coronavirus is going to mutate a tiny bit in them. There will be copies generated that would have mutated. Then those copies would come out and they would go into somebody else. And now that person has gotten slightly mutated version. Then there will be some mutation here as well. And then the next person would get it. And that doesn't mean everybody gets mutated version. Originals are traveling too. So now if you start looking at the genomic sequence of every version of the coronavirus in everybody involved, what you would see is you would see some standard version present everywhere. And then you would see some altered versions or mutated ones that are not present everywhere. Then you start following from there to see where is the first person. But I think it's going to be quite a difficult task to do. Then, COVID-US.org. Some studies are saying SARS-CoV-2 can directly infect neurons. How strong is the evidence for this? So COVID-US, I am actually going to talk about that. Somebody had tweeted that link to me as well. I want to see how the neurological pathologies of SARS-CoV-2 are, and I'm going to do a complete discussion about that. Question: if someone presents with symptoms that could be either COVID-19 or flu, would it be risky prescribing your COVID-19 meds? So no, no. I talk to someone and I see they may have flu or COVID-19. I cover them for COVID-19. I don't want to take a risk on COVID-19 at all. So over here, he's talking about ivermectin, hydroxychloroquine, not COVID-19. Would your risk delaying COVID-19 treatment until the patient was tested? No. My practice is that when I see somebody in the area of the outbreak, then they become a suspected case. And if they have those symptoms, I would start them. If they're asking me, I would start them. Of course, age and all those things can matter, but this is how I approach it. Any contraindications between ARV therapy for HIV and ivermectin, and if we should take, let's talk about this HIV and antiretroviral. Let's talk separately. I want to continue to focus on COVID here. MT question: COVID-19 luteolin article I found. So luteolin is another interesting thing that I want to talk about. So I'm going to put that away as well for the time being, and I'll do a complete talk on it. Rob from Florida, and Rob, thank you very much for your support. And Margaret, if you're still here, thank you very much for your support. Rob says, based on how PCR tests work, is it possible that even after a successful vaccination, a person could test positive to having the viral debris in their nasal passage, but not be sick or contagious from the virus, rather have contamination but not the disease? Yes. When we become immune, or we have antibodies, or we are vaccinated, that doesn't mean that we have gone against the virus to say you cannot come into our body anymore. Virus can still come in. Virus would be caught by immunoglobulin A that are in our fluids in our wet surfaces, or by the cells, which would very quickly respond to the virus and kill it or inactivate it. So the virus can actually enter the cells, and then immune cells would come and try to kill it, or the existing IgAs would kill it. So that means that if its test is very sensitive, which it should be, then if the virus has arrived in my mouth and it is broken down and you take the test, you might actually pick up copies that you would look at and say, yes, the person is positive. Scott Robinson, discuss the course of therapy for President Trump. His physician's decisions are being second guessed. So Scott, I have done one complete video talking about President Trump's therapy. Tenzo says, any reports coming from the Murdoch Children Research Institute on their phase 3 trial of the BCG? BCG, I'm still not very much sure that there has been a good outcome, but I would look at that, Tenzo. Debashi says, question, dear sir, please tell me some vegetarian food which thicken blood. So Debashish, I'm so sorry that I want to stay focused on COVID-19, but anything with vitamin K should help. James Kelly says, question, hello, Dr. Sayed, and thanks again for your fantastic teaching ability. Can you explain the mechanism of digestion, methylation, and histamine cycles, homocysteine levels associated to disease, and how B vitamins interact and play a role as methyl donors? This is a beautiful mechanism. I used to love it when I did biochemistry. James, I would do a complete talk about it. And Jumping Bean, can you postulate an equivalent to bromhexine? So we just saw today that a better equivalent to bromhexine is the nifamostat, or it is better than bromhexine. In US and Canada, who are willing to prescribe the prophylactic early symptoms drugs we use. So hydroxychloroquine and ivermectin are very important. And I wish that we can make them available. So that is a Twitter side. We are done with that one. I'm going to now answer some questions on the live and then we stop. Let's see if we have questions here. Question. So DP says, I'm not anti-vax, but I'm not going to be the first one in line for a vaccine. Is being skeptical about any vaccine wrong, especially one that's being developed so soon? No, I'm not an anti-vaxxer, and I do not recommend anti-vaccine anti-vaxxer stance as well. However, being afraid of a new drug or being careful for your own self is not bad. So if you are concerned, for example, when I become concerned, I look at the data. So if you're concerned, it is totally valid to say, I don't feel ready yet. For example, today the discussion came up that can the vaccine cross blood-brain barrier, messenger RNA vaccine, correct? You saw that tweet and my answer. But we also know that in case of Oxford and Moderna and Pfizer, we have transverse myelitis in some patients. And in the other patients, we have some other symptoms. Transverse myelitis means that something happened, that vaccine caused inflammation inside the brain tissue. So did the vaccine itself go into the brain tissue, or did it trigger the immune system, which then went into the brain tissue and caused inflammation? I don't know. And they haven't yet given that data or that thing. They simply said, this may not be relevant. But when you look at those things, you can say that, hey, I'm concerned. So DP, totally fine your position. Still, if you ask me that if a vaccine comes out today, after all those trials, would I take it? Yes, I would take it. Couple of more questions and then we stop. A simple garden. Question, is vaccine appropriate for those who have had COVID? If so, how many months post-natural infection? They don't need vaccine. Somebody who has recovered from COVID, they do not need vaccine because they have recovered. Their body's immune system was able to handle it. They don't need vaccine. Yes, after 2 years, their own antibody levels go down. Then at that time, a booster of vaccine may be needed. But please realize that just like SARS-CoV-1 went away, after vaccination, SARS-CoV-2 is going to disappear as well, because it would die down in the community. It would not have ways to move to others. DP says, thank you for answering my question. You are very welcome. Michelle says, I'm vegan. That is cool. Logic says, questions. Study says taking 1 gram of quercetin gets blood plasma level to 1.5 microgram, but you need 10 microgram or 25 microgram viral inhibition. Do you know if the levels increase with time? I do not. So this is something that we will have to measure, because quercetin is not something that is generally part of the labs. And so we do not know how much dose for how long to be given to accumulate the blood levels. Corey says, thank you again for your generosity and expertise. I never miss your work. Thank you. Thank you very much. I really appreciate it. For me, what is important is that we all sit down together. We are a tribe and we try to protect ourselves, our loved ones, and the people around us, hopefully global community. And that is what I really, really like. Perfect. So I think this is it for today. And we will... So Michelle says, question, which vitamin D is best without a prescription? So don't, unless there is an absorption, known absorption issue, or unless there is a known metabolism issue. For example, somebody who has irritable bowel syndrome, or who has inflammatory diseases of the GIT, and they cannot absorb vitamin D, then they need prescriptions. Similarly, somebody who has liver issues, and they cannot metabolize the vitamin D to the next step, they might need prescription drugs. Otherwise, if you're healthy in general, then normal vitamin C, that is cholecalciferol or ergocalciferol, if you take that D2 and D3 supplements, that should be sufficient. You'll absorb fine, and then it would go and metabolize fine, and then it would produce the active forms of vitamin D. So the question of, let's say if somebody got the infection today, like President Trump, and you want really to bring the vitamin D levels up to 49 gram, and his levels are below, and you cannot give oral tablets and wait for 2 months for these to slowly go up, then the other forms of vitamin D may be needed. So Marco says, every time I say this is the last question, then I see some more questions, and I want to make sure I can answer as much as I can. Marco says, if a given vaccine is 60% effective in producing antibodies, is it a safe strategy to take more than one vaccine type? Yeah, so that is fine. More than one type of vaccines would simply trigger. Maybe it is possible that other person who did not have the immunity triggered, maybe another vaccine would do it. So yes, it is interesting to do, but generally 60% would mean that herd immunity will be generated. Good question. I like this one. Thank you all. Thank you very much for today. Today is what, Friday? Tomorrow we'll see each other. I'll pick up one of the topics from here for tomorrow, and then we'll go from there. Meanwhile, please stay safe and happy. I know it is 1 hour 47-minute long lecture. It's not going to be shared at all, but still, please like, subscribe, and share. I'll try to do pieces of this if I can. Thank you, and see you tomorrow.